Eric is next, and I need another hand here. So, okay, we've got
Thanks, Cory. As someone who's spent a lot of time thinking about the overlap of movement and pain and attended all the Sarman courses, some of them twice, I think you've really captured movement and pain, this is my understanding with the literature, very well, and it's been a game changer in terms of what I've done as a practice. My question is regarding one specific patient. Maybe this patient is, maybe describe him as experientially avoidant, because a lot of what you're trying to do is tying movement in with someone's experience and linking those two things together. And this might show up as sort of apathy, maybe, or just you get a sense that they're not following you. And maybe just talk about how you work with that as a clinician.
Sure. So, yeah, that's another really good question. So, one thing that I'm always shooting for, again, I want these things to be coming from them. I want them to feel like they've gotten better of their own accord. So I'm looking for any way I can that whatever change or whatever idea comes about, if I can figure out a way that it is their idea, or if we can set it up so that the change was their idea, that is always going to be better than something that has been dictated to them. So in those cases, and I can remember one case in particular where this happened. I was working with this person. I cut my teeth in the Sarman method too. Some of you may know that was kind of my, that was what I cut my teeth in as a PT. And so anyway, I had just spent 45 minutes talking to this person about moving their scapula and doing this and that, and we were on the wall, and I mean, I just was working like crazy to try to get something through that made sense to him. And all of a sudden he turns around and he says, "Oh, I feel, man, that was pretty awesome that I just figured that out, that I just came up with that." And my immediate instinct, my ego was like, I just spent 45 minutes showing you this thing, right? But I didn't say anything. Luckily, I was standing behind him, so he couldn't see me go, "What?" But it was kind of a flashbulb moment for me that, like, that is exactly what I wanted. That was the best thing he could have ever said. That is exactly the response that I wanted with him. So trying to set it up so that they can kind of explore motion and see a change and it be something that they've done themselves, which is not easy necessarily, but that's always good. Another thing too is starting with small samples. Like Cara was saying, sometimes you don't feel like you're making an impact and they come back later and turns out that you have, you can kind of chip away with some of the stuff. And sometimes you've got to meet them where they're at. It's not exactly, you don't have to go full bore into the entire explanation process from the beginning. Start with something simple. It might even be just talking to them about, maybe they've come in with a surgical procedure in mind and, their neighbor or something has had this and they're just looking for their chance to go and get their MRI so they can get this disc cut out of their back and what have you. Start simple, throw out some research. It's good to have some research in your back pocket that you can say, well, we know that the process tends to play out this way, whether you do this or whether you don't. And so these are some things that we can try. But those are difficult, and I by no means, I fail all the time, right? I fail with people all the time. Some people aren't ready to hear what information that you've got, and sometimes maybe you aren't the person to be telling the information. Some of those things you can't change. I can't change that I'm a man. Some people might hear it better from a female. There's lots of things like that out there.
Yeah, thanks a lot, Cory. I've actually been using your stuff in the clinic for about a year, made a handout and the whole deal. And I find the same thing. I struggle a lot with many people who have a really difficult time being body aware. Most of the patients I have widespread pain along with some other pretty severe surgical issues and failed back pain syndrome, that sort of thing. So trying to help them find the edge is my biggest challenge, because they tend to go way past it every single time, and it's obvious in their body language that they're doing so, and even when I point it out and try to use subtle manual cues and verbal cues, they still have a really hard time understanding even what I'm asking of them. I wonder if you could speak to maybe some more subtle techniques for these kinds of folks.
Yeah, so a couple things. One, sometimes there are people who, they're like, I live on the edge. I'm at the edge right now, right? And so, like, every movement you've already crossed over. And I think some of the graded motor imagery stuff and some of even the, the mirror therapy stuff can be a nice way to even step back from this baseline. And you can go through the same concepts there. Another thing I would say is, again, if you go away from the site, so as far as helping a person figure out what the edge is, right? So one thing I like to, and everybody can try this if you like, if you put one hand out in front of yourself like this and you point your fingers down, and you just bring your hand out like this until you first notice tension, right? Yeah, bam. Sit next to somebody you like so they don't smack you in the face. Okay, once you get there, okay, that is an edge. This is hopefully, don't do this in a painful arm, but you do this somewhere else. And then, then you can say, okay, here's something I want you to try. Once you get there, pump that wrist 5 times at the edge. Okay, once you've done that now, do you still feel the same amount of tension? And a lot of people say, no, not so much. Okay, find the edge again. Okay, once you find it, again, go through 5 motions. Tension on, tension off. Okay, did it change? If so, you kind of keep. So that's a good way that I'll do this. I'll go somewhere else, and I'll show them in something that's simple and straightforward, and then I'll say, okay, now let's come back here. This is kind of what we're after. That's one way to do it. Yep.
All right, we have. I'm afraid here, but all right. And we have.
I'll do one, though I have more. You just talked about red flags and refer out, and I'm thinking, we actually, when doing this, possibly creating an increased level of threat for the patient, because most red flags are not validated. So we use these red flags as the truth, but when we test them, only very few are. So if we as manual therapists or massage therapists actually can decrease their pain, but we have a worry, shouldn't we try to decrease their pain and then say, listen, maybe you should talk to your doctor as well, just to be 100% sure?
Yeah.
Instead of, oh, shit, this is dangerous, there's a red flag, refer out.
Yeah, so I think of these things in levels to a certain degree. There are certain findings that you are not, this is a finding that is not appropriate for me to do anything with until you've cleared this out. If somebody's got a potential fracture, you need to get this figured out before I do anything with you. There are other things where, it is something more in terms of, this is something we need to keep an eye on, but this is not an emergency type of situation. And your treatment can kind of become a test for this. We can say, okay, we can run through some of these things, and if it's not going to help, we're going to know this pretty quickly. And I'll say to them, I'm going to want you to follow up with your doctor. I'm going to want you to follow up with me pretty quickly on this. But whether or not you've responded in the way that I'm expecting that you will, that'll have some input into what my next recommendation for you is going to be. Or I'll say, go ahead and set up your appointment with your doc. But in the meantime, I want you to try a few of these things so that when you see him, you can tell him what's going on, but you can also tell him that you've tried some of these things and this is what the response has been, because that's going to be useful information for them. So there are different levels of concern with some of these findings. Again, open fractures, a potential non-mechanical problem, these types of things I'm not going to mess around with too much. But in the majority of the cases, we're more looking at somebody who's worried. This is the more common one I see. Someone who's worried that they maybe have a slip disc. I don't know. Yeah, I know. But that's what they come in worried about, right? So, maybe I've gone through my testing, and their pain, their subjective pain, it doesn't cross the knee, which automatically gives me an idea that, it's less likely already. I sit them on the table, straight leg raise is negative. Okay, and I can kind of walk them through. These are some tests that kind of give us an indication that were that a problem to begin with, to worry about, that it's probably not there. But if they're still concerned about it, first of all, I'll kind of walk them through what we know about it. But then again, I'll say, okay, well, why don't you try some of this stuff, and then let's talk again in 2 days, and let's see what you think then. In the meantime, seeing me is never an either-or proposition. Just because you're seeing me does not mean you can go see your doctor right out as soon as you walk out of the door. If you feel like you need to do that, then go do that. But here are some things you can try in the meantime.
We have time for just one more.
Hi, Stephanie. Dosing.
Hey, Stephanie.
Is once enough?
One visit?
One application of these novel movements, for example.
It depends. Yes, maybe. So I didn't go into this. My other favorite thing to talk about is the method of how I deliver care. I work in the workplace. So I go to people's places of work, and that's where I work, and it's a whole different atmosphere, and it's great in a lot of ways. But because of that, a lot of the people I see are pretty early in the process. They can come in and see me whenever they want. And so a lot of times what we did up here is it. I mean, we do that. They've had a chance to get their questions answered. The big scary things, we've talked through them and kind of reasoned why that's probably not the case. We've established some things of ways that they can control it and shown them some ways to get moving again. And, okay, and then maybe we check back in and they say, nope, good. That they're right on that natural course history. And so sometimes that's the case. But in other cases, when, and I put as the goal, like if I back up to that slide, I put that goal as sometimes we're preserving self-efficacy. And those folks, pretty quick a lot of times. Sometimes we're building self-efficacy. Sometimes that takes a little bit longer. But there are other folks who it's almost like an absence of self-efficacy. It's the opposite. It's dependence. And in those folks, those things don't tend to change real super quick, and so they might need us around a little bit more. But there are definitely, in my case, because of the way I get to see people, there are a lot of times where I only see somebody one time, and I say, give me a holler if you have any more trouble. Yeah.
Thank you very much.
Yeah, thank you.